Hi, good morning. I'm Hugh Griffiths, an ENT surgeon working in sunny Birmingham. So got quite a reputation with the Peaky Blinders that may be not enviable. And I work at the Heart of England NHS Trust, which is a very forward-thinking trust, and I'm very pleased to work there. I think a silly side to pander to the myth of NHS management. We've talked a lot about partnerships and collaborative working already, and it's fascinating to hear our colleagues say much the same kind of thing, really, as we're going to say. Professional partnerships are born of often of necessity and pragmatism, sometimes utter desperation. And in ENT and thoracics, I've been an ENT surgeon for 12 years now as a consultant, and I've known my thoracic colleagues very well throughout that time. But it started with this kind of thing. This patient rolled up from a district general hospital with a parapharyngeal neck space infection, which they'd drained, put a track in. They found it had gone to the mediastinum, which is an instant cue to ship the patient to Heartlands for attention of my thoracics colleagues. Well, of course, we then get involved. So I get a phone call at some stage to say, can you do the neck while we do the chest? And so we collaborate on these emergencies. And this is one of ours. This is a patient who had a rigid esophagoscopy. Didn't go quite to plan, had a perforation, and so we called in our colleagues. And that's how the relationship sort of started, was that need to work together in the patient's best medical interest. I enjoy working with my colleagues. I learn a lot. And I think I'm a better surgeon, actually, having worked with my thoracics colleagues and also some of my ENT consultants. What I can lay claim to, having given the thoracics department, is this. This is the best SHO substitute you'll ever find. They're just Lone Star retractors, and they're great. And now the thoracics adopted them, and these are little perichondrial nasal elevators that we now use on the cricoid cartilage and on ribs. And these are neuropathies. Dip them in 1 in 10,000 adrenaline, pop them in the airway, and they're a great tamponade for hemostatic purposes. So there's benefits personally and professionally from working with colleagues. Where are we? So it kind of makes sense to take it from that emergency scenario and develop it in an elective situation. And we have common presentation. I see patients with shortness of breath. I see patients with cough, okay, as do my thoracics and respiratory colleagues. We have overlapping interests anatomically and in clinical conditions, particularly where the airway, the thyroid gland are concerned. We've already heard how subspecialization is now the norm. The surgical polymaths of years ago, they've disappeared. I knew Frank Collins, that was referenced earlier, and it's guys with that kind of breadth and ability aren't here anymore because we all narrow our focus. I trained as an ENT surgeon. I could do complex middle ear surgery. I could do complex nasal surgery. I don't anymore. I focus completely on head and neck, thyroid and airway work. So expertise, subspecialization comes at that cost, which is why we need to work with other people. Focusing on the difficult and the rare. I think there's times when we presented with problems and we obfuscate as clinicians. We think, oh, yeah, what am I going to do with this? I don't quite know. Bring them back maybe in 3 months. Maybe I'm being uncharitable. Their notes get bigger, but their problem goes necessarily unresolved. Whereas there are other people that we can work with in their immediate scenario to maybe come to a decision. It may not be any different, but at least we're arriving at a plan. Outcomes and guidelines are driving us to work together. I've just done a quick review of some of the literature on thyroid surgery, and what's coming out of the American Association guidance is the phrase high-volume thyroid surgeon. And the British Endocrine Society also come up with the same phrase for cancers, high-volume surgeon, which means 20 or 25 cases per year. You know? So you've got to kind of work together to keep your numbers up and, of course, to protect yourself and the patient. And it's easier, let's face it. It's a stressful life and a stressful world we inhabit, and if you can ease that, great. So we work primarily in these fields together. Let's move on. So this is a patient I operated on recently, I'd be happy to remove this thyroid, which is here, from the neck, as long as my thoracic colleagues had seen the slides, or seen the images, seen the patient, and were around, okay? It's rare that we split the chest these days, maybe 2% of the times in these retrosternal thyroids. We don't do it often, but when we do, we want to be prepared for it. So that preoperative phase of workup is very important, that they see us all and have the opportunity to chat to us all. Oops, not working. There we go. I'm going to stop there. Melinda, you want to say a few things? Or is there another slide? Oh, no, not yet. Sorry. So this patient, this is a patient that we set in the clinic together. In ENT, we use flexible endoscopes. You've got fantastic stack systems which record and save that information. And this patient came with what looks like an infraglottic. These are the vocal cords here. This is an infraglottic stenosis. Query why? Well, the airway is a continuum, okay? And we start in the nose as ENT surgeons, and we stop here, where you guys take over. And this patient, this is her nose, okay? So the diagnosis became immediately obvious to me as an ENT surgeon, because this is the septum, this is the lateral wall, the left side, and this is a crusting that, along with the supratip deformity, we call it a boxer's nose, where you lose the quadrilateral support and the nose kind of collapses. That's fairly indicative of a vasculitis. So it's a spot diagnosis for an ENT surgeon, but maybe not for thoracics. Right, these are normal vocal cords, something many of you may not have seen in action. So we record this kind of image in the clinic, and it's lovely. I love this slide. She's a singer. That's the most perfect larynx you'll ever see, all right? Not so perfect is this one, okay? So this isn't a post-operative patient. This is nobody's fault. This is idiopathic, as we call them, called palsy. But there's two presentations I want to just relate to you. So this patient has a left cord palsy, left being this one, obviously. So you can see the right opens, it adducts, and it closes well with its counterpart. So this patient has a normal voice, okay? They'll come into clinic, whether it's post-op or not, and they'll speak normally. And that, for a lot of surgeons, means everything's okay, they're fine. But walking upstairs, running for the bus, they're breathless, okay? So if you've operated the mediastinum, if you've done your thyroids, you need to examine the cords to establish that they've got palsy. You can't just listen to the voice. This is also a left cord palsy. This is the other type of presentation we see. If you look, there's a big gap there where the cords come together. Okay, so they're not, is that the right one? Yeah, it is. There's a gap there. Okay, so this patient has that breathy, weak voice, which is fairly classical of an injury or of an idiopathic presentation. Okay, this is another slide, vocal cord dysfunction. One of the things that we've noticed, Melinda will reference the clinic that we do together on airways. It's not just anatomical problems that we see and manage, okay? We see function issues with the cords. So we lost sound on this, so I'll try and talk you through it, okay? So we're looking down at the, they move normally. Okay, in a minute, we can ask the patient to breathe in, there. In a minute, there, that's breathing in, all right? So if you were listening to the sound, which we haven't got, that's a monstrous stridor. So these patients present to A&E, like this, they present to us. The last thing you want to do is give them a tracheostomy. The last thing you want is surgery. This is where working with our speech and language therapy colleagues and our physiotherapy colleagues works, because those patients don't need us as surgeons. This is just an example of some of the rare stuff that we see. But even though this is a supraglottic lesion, having thoracics input, because they use different lasers to me, is very helpful. This is a lady with plasmacytosis, which has occluded the upper airways. That's the vocal cord there, okay? So you can see that there's very little room at all. No, we don't have that video. Okay, let's move on very quickly to thyroid cancer. This is a PET scan of a chap with a very, very aggressive medullary thyroid carcinoma, and he was operated on jointly by ourselves, thoracics, and the cardiovascular surgeon was there as well. Seeing these patients like that jointly is imperative, I think. It has huge prognostic implications. If we can't remove the Met, what are we going to do? Consenting and the patient agreeing to this kind of surgery depends on understanding fully the nature of what we're about to do with them and the potential consequences. Now, I can't talk about much of that where the chest is concerned, and Meninda and his colleagues can't really relate as well to the neck, so we need to all be involved. There's also the issue of how much surgery we're going to do for him. When I started out, we'd do tracheal shaves. As an ENT surgeon, I didn't have that confidence to chop the trachea and anastomose it, so we'd shave it. And that's a pretty poor operation, really. It's not really oncologically sound. And of course, there are huge implications how we set this up. That patient went to a cardiothoracic theatre and had 4 surgeons available once we'd worked out what exactly was necessary. So some relationships like Cameron and Clegg never really get off the ground. Some last for decades and are the source of great pleasure for millions. So yeah, we'll skip. We've seen that already. Okay, I'll stop there. Okay.
Thank you. So next few slides, I'll just dwell on the collaboration we have fostered at Heartlands Hospital with the ENT surgeons in the management of airway problems. And as we know, the airway basically has 2 components, larynx and trachea, very intimately related anatomically, have similar disease process, often span the boundaries, but for some reason are managed by ENT and thoracic surgeons who have a very different philosophies and concepts. And that at times leads to less than optimal outcome. Just give you an example. We as a thoracic surgeon will deal with any case of Stryker and the VCD1 he mentioned and deal with it without really concentrating on that area. And the consequences that you may have a problem with phonation, deglutition, or even the airway problem will become worse. And similarly, there are ENT surgeons or the respiratory physicians who will endlessly keep doing endoscopic intervention in the form of dilatation, laser disobliteration, and what that does is that it makes the things more complex. There's a sort of increased problem with dealing with these surgically at a later stage. And also, these problems are not very common. None of us can claim expertise in managing it, and that's why it is important to collaborate with people who know a little bit more about it. And also, we know that these problems are moving more and more towards the larynx, and hence the necessity for this collaboration. And nothing can give a better example than this patient who has got a enlarged thyroid, had a tracheostomy performed, has got a stenosis at the tip of the tracheostomy. So this needs a collaboration. I can't go and deal with all of that. And with that in mind, we decided that we need to make it a little bit more structured, and we came up with this, what we call Regional Airway Management Interest Group. So it comprises thoracic surgeon, ENT surgeon, and respiratory physicians from the region, and we have our local radiologist, speech and language therapist, and the physiotherapist sitting all together. And we try to meet once a month, and we assess these patients jointly in that clinic or a meeting, what we call it. And we look at all the investigations, and we decide what more needs to be done about these patients before we can make a diagnosis. And then we have an idea where the problem lies. What is the cross-sectional area of the stenosis, for example? What is the length? What is the relationship to the cords? How the larynx is working? How the vocal cords are working? Is there a problem further up there which is actually contributing to the problem? And we record all that. And then you have a sort of a diagnosis, whether the problem lies supraglottic, whether it is at the glottic level, or it is subglottic, and whether there is any further associated problems like Malaysia or that there is any other dynamic component. And we have a clear plan what we need to do with this patient. And what we do then is, again, pretty much collaboratively. For these patients, we are together in the operation theater, either treating the problems transorally or endoscopically. For example, in this one, there is an adhesion between the 2 ends of the vocal cord, or we have open method of dealing with these problems. And we started with the simple tracheal resection reconstructions, and as we have gained more experience, we are taking increasing bits of the cricoid and further cricotracheal resections, and lately we have started undertaking in selected patients the laryngeal fissures. And as Hugh said, there are other problems which we see on day-to-day basis. Somebody has a retrosternal goiter or a large goiter removed, patient gets transient malacia, and then you are there to deal with or give some advice on the management. And most importantly, I think Hugh has already mentioned about the invasion of the trachea with thyroid cancer, and there's a more and more tendency now, and there are more understanding by the ENT surgeon that shaving it off the trachea is not correct, and I think we need to be a little bit more radical about it. Occasionally, you will be called to undertake mediastinal tracheostomies for the patient who have undergone extended laryngotracheal resections, and you are better placed to do it. And then you always have this problem, concomitant lesions. What is it, a metastasis or a primary? Hugh, can you close the patient, please?
Yeah, just want to illustrate with the last slide how a multidisciplinary kind of approach works. I think I work very closely with speech and language therapists. In what I do is I do a lot of voice work as well as head and neck surgery. And I think we've got a case that illustrates that, where we've all been involved, really. This is a young lady who came to us with subglottic stenosis, which was just encroaching on the glottis, actually, and she had a laryngotracheal resection. So you can see here the nasogastric tube, there's the cords, and in the distance there you've got a small trachea. So I'm going to play this. I need to learn to edit slides. It's a bit video, so a little bit on the long side, but bear with me. Okay, so ostensibly you'd say, well, they're opening, they're closing, that's a functioning glottis, okay? She's about 5 days post-surgery, I think, at this point, okay? So the airway is pretty good, but the cords are shortened, particularly on the, okay? We take the anterior arch of the cricoid cartilage, of the cricothyroid muscle, doesn't really work anymore, so it doesn't lengthen the cords. I'm encroaching really close here, and I'm touching the arytenoid. Normally that would induce a cough reflex or a response. There's absolutely nothing here from this lady, all right? So that tells me this is not really a functioning larynx just yet, okay? That mild edema there and the pooling behind the cords and the lack of sensation mean that we can't really start her eating and drinking. She needs a few more days for that sensation to improve before the cricopharyngeus muscle will open properly and she won't pool, penetrate. The last thing you want is a patient after the surgery, here we go, I'm going to touch it there, and there's no response, okay? It's the only way I know how to test sensation, really. Blowing air doesn't really work, okay? So she's not ready to eat and drink yet. But that work is largely done by the speech and language therapy team. And it's not only that kind of physical aspect of the care, the medical aspect of the care, it's the patient's well-being. And what we found, so in my experience anyway, is that the therapists bring a touch of humanity and normality to the post-operative healing process. And this lady benefited enormously from those conversations and that interaction she had. Things that maybe as surgeons we're not so good at, but there are people with us who can support the patient in ways that we can't, okay? So it truly is a collaborative approach, and one day I think I'll end up trying to stop this. It doesn't want to stop. There we go. Okay, thank you.